Welcome, everybody. I know we've got folks from all over the country joining us, both East Coast and West Coast. We appreciate you taking out a little bit of time on your Thursday afternoon. I'm Brian Rose. I am a cardiology PA at First Health of the Carolinas in southeastern North Carolina. I'm also the president of the Academy of PAs in Cardiology, and it's my pleasure to introduce not only my friend, but a mentor, as one of my mentors as well, that Dan Bensimhon, who's the medical director of advanced heart failure and mechanical circulatory support at Cone Health in Greensboro, North Carolina. This is the first of hopefully many webinars that we will do with APAC. And tonight we're going to be talking about strategies to reduce heart failure admissions. Special thanks to tonight's sponsor, scPharmaceuticals. Just a brief outline, we're going to discuss the state of heart failure in the United States, identify issues leading to hospital admissions and readmissions for heart failure. We're going to discuss the congestion dilemma, the role of diuretics and bioavailability, and a novel device known as FUROSIX and the trials that got it to market from concept to clinical application. So as we stand, well, this is a little bit of a dated statistic, but we're kind of right in the middle of these two dates. In 2019, there were about 6.7 million individuals with heart failure. It was the #1 cause of hospitalization for Americans greater than 65, and 25% of patients that were diagnosed with heart failure were readmitted to the hospital within 20 days. Unfortunately, we're on the wrong trajectory. By 2030, 8.5 million patients will be affected with heart failure. This will equate to roughly 1.3 million hospitalizations annually for heart failure in the United States. And probably more sobering, 1 in 14 patients with heart failure will die within 30 days post-discharge. So if we look at heart failure annual risk, let's look at it in context. We know ASCVD well, we know the risk associated with it, but when we compare it next to heart failure, when we progress from stable heart disease to patients with worsening heart failure symptoms, readmissions, all the way up to those individuals that need advanced heart failure therapies that are intolerant to guideline medical therapy, their risk becomes extremely high. This is a graph that depicts this exact disease progression that shows that with each subsequent heart failure event, decompensation, hospitalization, mortality rate, and thereby survival is significantly reduced. So readmission trends. So 1.29 million patients with heart failure admitted to the hospital in the United States. 80% of these admissions and readmissions originate in the emergency department. Congestion is a constellation of symptoms to include edema, weight gain, orthopnea, dyspnea, exercise intolerance, and fatigue. And this is really the crux of what we're going to talk about tonight, is this dilemma, if you will, of congestion. Year after year, heart failure continues to be the leading cause of hospital readmissions, as we just saw. Staggeringly, 50% of these patients are still congested at the time of discharge. There's significant financial consequences of heart failure. After a de novo heart failure diagnosis, a worsening heart failure event, the average cost per patient for heart failure is anywhere from $25,000 to upward to $105,000. Roughly 80% of those associated costs are related to in the hospital care of that patient. By 2030, those costs are expected to exceed $70 billion, yes, billion dollars annually. On the right is a pie chart that shows exactly what those expenditures are. 80% are related to the hospital. Only 2 to 3% are spent on drugs for treating heart failure. Congestion affects outcomes. Patients that are admitted with acute decompensated failure are wet. those that are at discharge that are still wet are at a much higher risk of not just rehospitalization, not just within the first 30 days, but all the way out to 1 year. And those patients had significant mortality associated with those readmissions. So this is the trajectory of congestion, and Dan is going to go much more in depth with this as we move throughout the evening. But essentially, this is where our patient is. They start from a hemodynamically stable state. They develop lung fluid, filling pressure increases, those autonomic adaptations occur, increasing intrathoracic pressure, weight change and symptoms, and then they're in hospitalization. Unfortunately, what happens is once they are hospitalized, they're not ever decongested back to the point, or the majority of folks are not decongested back to the point where they are, quote, hemodynamically stable or in that green where they have decreased filling pressures. So assessing congestion is guideline therapy or guideline recommendations. So consistent with the AHA, ACC, HFSA guidelines that came out in 2022, we should not only be assessing patients in the clinic, but also in the hospital, okay? Clinical congestion should be assessed at each encounter to guide overall management, including adjustment of diuretics and other guideline therapies. Class 1 recommendation. In the hospital, same thing. Patients should be assessed to guide triage and initial therapy and establish optimal volume status targets. Assessing congestion, this is a more recent JACC scientific statement that came out in June 2023. Early telemonitoring of weights and symptoms did not decrease heart failure hospitalizations. A signal that is accurate and actionable with response to kinetics for early reassessment is required. And tracking of congestion with cardiac filling pressures like CardioMEMS or cardio or lung water content, which is known as the REDS device, and we'll talk about soon later in the presentation, has shown most to impact to decrease these hospitalizations. Put simply, we can't just say that assessing congestion in patients is enough. We actually have to have some sort of actionable measure that lets us know how congested that patient is, either than just our subjective thought of whether or not they are congested or have they decongested completely. So just a few ways to measure congestion. These are some are commercially available and some are future. There are wearables, which I know many on the call are use, including myself, to measure that intrathoracic impedance. CardioMEMS have been out on the market for a little while, which is actually an implantable device. A REDS, which is in the bottom left of your screen, and that is an absolute measurement of lung fluid volume. And Dan can speak a little bit more to his work with the REDS device. And if you watch Mr. Wonderful from Shark Tank, you might have seen him talk about the future cardio device, which will be a subcutaneous implant. And that is in trials and pending FDA approval. I will turn it over to Dan at this point.
Thanks, Brian, and thanks everybody for joining us tonight or this afternoon, depending on where you are. As Brian said, I'm the medical director of the Advanced Heart Failure Program at Cone Health in Greensboro, and been asked to talk a little bit about congestion and how we assess congestion and what are some of the pitfalls that we run into when trying to decongest patients. So I just think, as we all know, diuretics are the mainstay of treatment for patients with heart failure, and whether that be acute decompensated heart failure in the hospital or chronic heart failure management, they really have been for a long time the mainstay. Promisingly, though, as we now see a bigger emphasis on guideline-directed medical therapy, both for HFrEF and HFpEF, we're starting to see that a significant amount of patients are now coming off their daily diuretic dosing, their daily loop diuretic, because we get diuretic effects from Entresto, we get diuretic effects from an SGLT2, we get diuretic effects from an MRA. So if we're doing our GDMT right, our reliance on diuretics as part of daily therapy typically goes down in these patients. But that said, still a significant number of patients require it for daily therapy, and every patient or all patients require in times of decompensation. That said, using diuretics, isn't always easy. Which agent should we use? We know we should use probably loop diuretics. Are there differences between them? Which dose do we use? Don't want to box their kidneys, but yet we want to be effective. And how do we get through that? And complicating the matter is diuretic resistance. And diuretic resistance is really what I'll say is, in my mind, a junk term, right? It's a very all-encompassing, very broad term, but it really gets to the fact that despite increasing doses of diuretics, patients remain congested. And this happens in 30% of all patients that we treat for heart failure, that the ability to remove volume is limited by blood pressure, limited by renal function, that you just can't come off with medical therapy alone. I like to think about it in two ways. One is I like to think about this as pseudo resistance, which means that the patient isn't really fluid overloaded and we're overestimating fluid status. And I think Brian's point about using devices to help us assess these patients objectively is really, really important. I think especially happens in HFpEF, where people tend to be obese and have other comorbidities, renal failure, COPD, and sleep apnea that make the assessment of volume status and how to attribute their symptoms very difficult. And another form of pseudo-resistance is non-compliance. Patients saying, yeah, I've taken my Lasix, I'm not peeing and nothing's going on. And truth is, you put them in the hospital, you give them one dose of Lasix and they pee like crazy just because they haven't been taking their diuretics. When you think about actual resistance to diuretics, lots of different factors come into play. Perhaps the largest one is just inadequate dosing of diuretics, and that's what I call diuretic fear, right? We're always fearing that we're going to hurt someone's kidneys because we're hitting them too hard. And I think if you're dealing with a lot of heart failure patients, you need to get that out of your mind, right? There's very few people we're going to injure with high dose diuretics if they're truly volume overloaded. Low cardiac output state. So if people aren't perfusing their kidneys, then the kidneys think their patient is dry and will not give up the volume. That's a problem. Poor renal perfusion, hypovolemia, RAS activation, increased fluid absorption, sodium absorption, other things that you can sort of add to the list, but are more complicated than what we need to touch on tonight. Next slide. So I think it's important to understand a little bit about the pharmacology, and I'm no pharmacist or pharmacologist, but I think it's important to know a little bit about the pharmacology of Lasix. So the first thing you need to realize, loop diuretics are threshold drugs. So if you don't get above the threshold, the plasma level threshold, the patient is not going to pee. So if the threshold is 40 milligrams, and you give patients 4 doses of 20 throughout the day or 1 dose of 80, they will not respond to the 4 doses of 20, but they will respond to the 1 dose of 80 because you got the plasma level over that threshold. So the amount you give, so often when I'm talking to patients, I'll ask them if they're volume overload and say they're on Lasix 40 BID, I'll say, do you pee when you take your Lasix? And if they say, no, I don't pee when I take my Lasix, then the immediate thing to do is increase the dose of the Lasix. If they say, yeah, I pee, but I just have more fluid on me, then sometimes it is just to give them an extra dose instead of 40 BID, maybe 40 TID. Just really getting a sense, are we hitting the threshold? And then when patients get congested, realize that getting to that threshold gets more difficult. So if you have fluid on board, you have fluid in your gut, you are not going to get the same plasma level as diuretic. As if you're in a decongested state. So you have to, one is try to increase the dose. And if that doesn't work, have to look for alternate ways to get the plasma level of the diuretic up. And so why does this really matter? And it matters, as Brian pointed out, we've learned a lot about the trajectory of congestion from implantable sensors. And if you see Phil Adamson's sort of depiction here, this is sort of what we got from CardioMEMS. We know that the changes of decompensation of heart failure come about 30 days before an admission comes. So filling pressures increase, intrathoracic pressures increase, impedance increases, and patients throughout this remain completely asymptomatic and often with no weight change. And they're kind of just kind of sitting there struggling a little bit. And then all of a sudden, they get symptoms and their weight change. Symptoms and weight change is a late signal, or are late signals. They happen between 5 and 7 days before an admission. And what piggybacks with this is that at the same time that you have these symptoms and weight change, you now are building diuretic resistance. So at the same time that you need to get these patients decongested, you have the inability to treat them adequately with oral diuretics. So it really leaves you have one shot, like in 5 to 7 days. If you don't get the fluid off, that patient's going to be in the hospital. So you really have one shot to get it right before they end up in the ER. And it's really important to know where your patient is. If you can detect them early, you're going to be much more successful with orals. If you detect them late, you better have another plan. Next slide, please. So how do we overcome diuretic resistance? So one is earlier identification of congestion. Get them early. Use devices where you're picking this up early. They'll respond to their oral diuretics. The other one is, pound them, right? Increase the diuretic dosing. Try to get that plasma concentration up. Escalate or switch to an IV or subcutaneous form of where you take out the ability, the gut edema and the other things which are limiting absorption. Find another pathway to get it directly into the bloodstream and control plasma levels better. Think about combination therapy. We have some data about adding thiazide diuretics and carbonic anhydrase inhibitors like acetazolamide, sodium restriction, and for people who are low output, if they're not perfusing their kidneys, we give them inotropes. And then finally, when you raise the white flag and you give up and said there's no way fluid's coming off this patient with diuretics, then we think about other non-diuretic strategies. And often you think about ultrafiltration. There's a new device that's in clinical trials right now called Aquapass, which is a robe that actually makes people sweat for several hours a day, and it gets out about 200 cc's of renally independent fluid off through a sweat vest, and helps to reduce the reliance on diuretics. So interesting things coming down the pike when oral diuretics fail, that you'll be hearing more about. Next slide, Brian. So I just want to focus a little bit on inpatient diuresis, and you can see this slide and get a really big headache. So I'll try to make it pretty easy on people. Like, how do we do diuretics in the hospital? And I will say one statement if I can just say one statement to cover it hard, hit them hard. Like, do not underdose diuretic. Like, if you're giving anybody 20 milligrams of IV Lasix in the emergency room, either that patient shouldn't be in the emergency room or you're doing the wrong thing. So almost always, I start with 80 milligrams of IV Lasix in the ER, and oftentimes more than that. There's a little bit. We have some data from the inpatient world about what works. I think probably the most important data about this was from Mike Felker with the DOSE trial, which is almost 15 years old now. And Mike and I were fellows together, so I think I'm dating myself a little bit. But what they did is they looked at patients who came into the hospital who were congested, and they randomized them as a 2-by-2 format. They randomized them to high dose Lasix, which was their oral dose, 2.5 times their oral dose changed to IV. So if you're on 40 BID, that's 80 milligrams. They gave these people 200 milligrams total of IV Lasix. And then they used versus just taking the oral dose and making it IV dose milligram for milligram. And then they did IV, a drip versus bolus therapy for these patients. And what we found out is that there was no difference between drip and bolus, but there was a difference that higher dose diuretics worked better, decongested patients better, and reduced hospitalization time and symptoms more effectively than lower dose. And once again, that was 2.5 times their daily dose of diuretics switched to IV. The next trial was a trial of ultrafiltration. There was an earlier trial called Unload, which showed a pretty good benefit of ultrafiltration for these patients. Cardiologists led ultrafiltration for these patients to remove fluid and showed improved weight loss and improved fluid management in this patient. The follow-up trial was a large trial called Caress, which also looked at ultrafiltration. In the Unload trial, they let cardiologists manage their own diuretics. In Caress, they used the dose trial algorithm for diuretics. And in this trial, they saw no benefit of ultrafiltration in this patient population versus the high dose diuretics recommended by the dose trial. So that was really why we saw ultrafiltration sort of fade into the background. It's starting to come back now. I'm actually a fan of ultrafiltration in the right patient population that's not responding to high dose IV diuretics. Then there were other things like Reality HF, which was a Japanese trial, it's a registry trial, and showed time to diuretics. The faster you get on the patient, the more effective it was for that patient population. That's confounded by the fact that if you understand that it's heart failure earlier, patients are going to get treated differently, and maybe that's a confounding factor there. And then finally, we looked at it looked at a trial of bumetanide or Bumex plus or minus acetazolamide and showed no difference by adding acetazolamide or Diamox to them. More recently, we've had a trial called ADVOR, which came out a couple of years ago, which did show a benefit in diuresis by adding Diamox to this patient population. And I'm a big fan of using Diamox in people who have a contraction alkalosis, people who have chronic lung disease and things like that. I think it works well in that population, but lots of data out there. I think one of the most interesting trials that came out recently was the 3T trial. And the 3T trial looked at patients who had diuretic resistance. This was a Jeff Testani trial from Yale and looked at people who had diuretic resistance, so less than 2 liters out of fluid out on high dose Lasix. And what they were randomized to is 5 milligrams BID of metolazone, 500 milligrams IV BID of chlorothiazide injections, and then tolvaptan 30 milligrams daily. And they looked at weight loss and diuretic efficiency. And what they showed is all of these strategies, all 3 of these strategies were equally effective. They had different pluses and minuses about sodium absorption and things like that. But from a clinical efficacy, all of them showed better urine output and better diuresis and a relatively good safety profile at how you wanted to use it. Now, cost things are a little bit different. Obviously, metolazone probably the cheapest option in the bunch, but just to saying that there's a lot of options out there, and this is often why we scratch our heads like, what are we gonna do? And I will say, just for the quick and dirty, the first thing to do is increase your rate of increase your dosing of diuretics. Even if the creatinine is bumping a little bit, realize that renal congestion, renal vein congestion, volume overload itself will cause an increase in creatinine. Decongesting, effective decongesting will often improve renal function and not hurt it. Now, obviously, if you're hitting them hard and they're not moving, then you have to think of other therapies. Next slide, Brian. So this is how I often say to our trainees of how do I think about where this patient is and how the fluid moves through the body and what are the factors I think about when I'm assessing diuretic resistance. So look at the blue boxes, realize where the fluid is. So the fluid is in the tissue. Like if they have edema, fluids in the tissue or in the interstitium, it has to move into the vasculature, then it has to get from the vessels to the kidney, and then it has to get from the kidney out. And so in each one of these things, where are we failing? What isn't working for this patient? So from getting fluid from the tissue to the interstitium relies on hydrostatic and oncotic pressure. Do they have low albumin? What are they doing? Make sure you wrap them up, get their legs elevated, whatever you need to do. Now the blood's in the vasculature. We need to get it to the kidney. Is your cardiac out? Patient's not responding. Is your cardiac output okay? If the cardiac outputs, if they're not responding, you think the cardiac output's not okay? put a catheter in, measure their outputs, and figure out, is this a cardiac issue? Do they need inotropes after load reduction? And now the fluid, the heart pumps the blood to the kidney, and you're still not diuresing, you're not excreting it. Is it your diuretic dose is inadequate to get to threshold? Is it bad renal function? What are the strategies to get from the kidney to the bladder, right? And that's increase your diuretic dose, change to IV or sub-Q, and then combination diuretic. So break it down. Like think about each stage. What can I do for this patient? And where do I think the problem is? And then go after that problem to understand what you need to do about it. So just a simple schematic that I created for us, for our folks on rounds to kind of think through this process. Next slide, please. So what about the outpatient setting? Obviously we all try to be able to diurese our patients in clinic, and IV diuresis can be tricky in clinic. If you want to upset my nurse, the first thing you can do is order IV Lasix on the first two patients who walk into clinic, and it's going to be a bad day for everyone in clinic that day, because it's a lot of work, it's a lot of follow-up, and it's the right thing to do often, but it's not an easy thing for our staff. Um, uh, Only about 20% of clinics can offer this to their patients. But I think the real thing to measure here, to say here is, and I'll show you a little bit more data on this as we go. Single dosing strategies are just ineffective. You can give, if somebody comes in is congested to the point where they need an IV dose of diuretics, and you just give them one dose, you've taken the top off the cup, and you've left the cup really, really full. It's really just a Band-Aid on a problem. You can't give someone one dose of IV diuretics and think you have them back to hemodynamic stability, as Brian pointed out. You have to have a contingent plan to continue to diurese that patient. Next slide. So this is just a little thing of looking at loop diuretics, like which one should I choose? Is there one better than the other? How do I know? And the answer is who knows? We don't really know. You can see that torsemide, furosemide, and bumetanide, they all have pretty high bioavailability. Furosemide probably has the biggest variation in bioavailability based on gut edema and other things. Torsemide and bumetanide tend to be more bioavailable, and that's why a lot of us favor them in right heart failure when patients have a lot of gut edema. We think they probably get better absorption in patients with right heart failure. That said, if you look at a head-to-head trial, there was an initial trial called Toric, which showed some benefit of torsemide over furosemide. People were pretty interested in it. Then Rob Mentz, who's a leader in heart failure at Duke, put together the Transform HF trial, and this looked at people, almost 3,000 patients randomized to furosemide versus torsemide at hospital discharge, and basically no difference, no change in mortality, no change in heart failure readmissions. There was a lot of crossover between the groups, and there was non-compliance and stuff, so it's not a perfectly clean trial, but I think there's no hard and fast rules here. My rule here is people aren't responding well to Lasix, and you think they have a prominent component of right heart failure. I'll switch to Bumex or torsemide to see if it works better for them. Next slide. So how to think about this differently, right? If you go back to our diagram where we showed the levels of congestion, the progression of congestion, and people come to you or call your clinic on a Friday afternoon and they say, my weight's up, I'm symptomatic. You're going to say, double your diuretics, and there's a 50-50 chance that that's going to work, and they're going to be in the hospital Monday morning when you get back on service. So how can we be more effective? How can we give these patients, we need two things. We need the guarantee or almost a guarantee that people are going to get effective diuresis. So we need to get the plasma level up. And the second thing we need is consistent therapy. We can't just give them one dose, because what happens is if the cup is full and you get to the point where you have symptoms, you give them one dose of diuretics, you get below the level of symptoms, but you still have all of this other cup that's full. And you have not completely decongested them. They may be symptom free, but they're not completely decongested. As Brian pointed out, 40 to 50% of people who leave the hospital, they are symptom free, but they leave the hospital with congestion. People walking into your clinic, 30 to 40% of patients who walk into a heart failure clinic have subclinical congestion that we're not getting. So we need something that gets is effective at the time of crisis and that you can give multiple doses. And this is why Furoscix has come to market. Think about it. It's another tool in the toolbox. It's a tool. There was a gap we didn't have. We had oral, we had IV, and we had IV was really restricted to the hospital, orals in the clinic. We had nothing to really bridge the gap to keep these decompensated patients out of the hospital. So as you can see, Furoscix, it uses the Repatha pump. It's a subcutaneous device. It's for 5 hours. You get 30 milligrams of Lasix in the first hour, 12.5 milligrams for the next hour. You can use it once or twice a day. It's super simple. People say, well, somebody's obese, it's not going to get absorbed well. All the capillaries are right below the skin. They're not above the adipose tissue, so this works well no matter what patient size is and things like that. And you get, as you'll see from the next couple of slides, you get very effective dosing of this compared to IV Lasix. So next slide. So this is the pivotal PK/PD data that got FDA approval for this compound several years ago. And what you can see on the left is these are plasma levels of Lasix. So you can see that they got 2 intravenous doses of IV Lasix in a 2-hour period. So you see a peak in plasma concentration, a decrement, a peak again, and then you get the runoff of the IV plasma levels. The Furoscix is the blue curve, and you can see a very steady rise to steady state. You get a nice steady state over the 4 to 5 hours that the patient is using the device. You get up over threshold, you stay over threshold, you get good diuresis. The area under the curve for these two curves is exactly the same. So 99.6 absolute bioavailability compared to Lasix, and you can see it. It makes a lot of sense whether you're looking at a diuresis or natriuresis. You can see over 8 hours, 8 hours or 24 hours, you get the same amount of diuretics, 2.7 liters and 3.6 liters at 24 hours. So this was the pivotal trial in heart failure patients that showed that this compound or this device drug combination gives you the same effect as intravenous Lasix in decompensated patients. Next slide. So this is a study done by Stu Russell and Dr. Malhotra at Hopkins in their Bridge Clinic. And what they did is they took patients who had a recent heart failure event, and these patients called clinic and say, hey, I'm not feeling well. I'm short of breath again. I got symptoms, blah, blah, blah. And they randomized them to 1 dose of IV Lasix versus a dose of Furoscix, 80 milligrams of Furoscix. The physician at the clinic or the provider at the clinic could determine what dose they wanted, up to 160 milligrams of IV Lasix. About 60%, probably about 50 or 60% of these patients received 160 milligrams of IV Lasix. 58%, there it is. The average dose was 123 milligrams, and that was compared to 80 milligrams of Furoscix in the standard device administration. And you can see the outcomes were exactly the same, about 1.4 liters of diuresis above and beyond their oral diuretics. They felt better. They went home from clinic, and almost half of those patients got admitted within 30 days because we didn't do anything else to get really treat their congestion effectively. If you're just going to do 1 dose of IV, you might as well just not do it. The resources involved are just not worth it when you look at these kind of results. Next slide. This is a trial we designed. This is called the Freedom HF study. Designed it. This is a 3-center trial, including in our hospital. And so we knew from previous data in our hospital that a significant majority of patients, or a significant percentage of patients who come to the hospital, come to the ER for heart failure um, are either not congested or just mild to moderately congested. That said, in our ER, over 90% of those patients are going to get admitted to the hospital for further treatment. Whether you like it or not, you're on the receiving end of it. And you ask ER doctors, like, this patient's not that bad. Why are you going to do it? And the answers are always twofold. Well, Dan, they came to the ER, so they feel, whether it's true or not, that their current therapy is ineffective. If I send them back home on their current therapy, they're just going to come back. And the morbidity and mortality of heart failure is so high that if you take a patient who has decompensated heart failure, I don't want to be the last name on their chart without doing something differently. So we designed a trial to say, what if we developed criteria to say this is a patient who is volume overloaded, but stable? This is a patient who could probably be seen in the clinic and sort of triaged, but they're now coming to the ER. Could we U-turn that patient if they meet certain stability criteria and get them home from the ER with good follow-up and FUROSCIX? Um, so we compared that patient. So not only do we look at can we get this, can we U-turn the patient out of the ER, but what's the cost to the system? Is there a cost savings in here? And realize this was done just before COVID or right around the COVID time. So, bed space in the ER, everything was at a real priority here. And we had an internal medicine resident in our hospital sitting down at the ER, flagging these patients for the ER staff saying, can we get this patient home? So there's 24 patients who got enrolled this way. The criteria were that the ER doc or provider had to see the patient and say, we are admitting you for heart failure to the hospital. And then they had to meet certain stability criteria. They couldn't have a new oxygen requirement. Their blood pressure had to be stable. Their heart rate had to be under 100. Their serum creatinine had to be stable. And they had to respond to one dose of IV Lasix in the ER. If they met all those criteria, we could send them home. So we talked 24 patients into it, and we interrupted this thing, and we said, listen, we enrolled these patients. Everyone got FUROSCIX. We gave them several doses. I'll show you the study plan. We gave them placed a dose, a pump on them in the ER, and most patients chose to activate it once they got home. They didn't want to pee on the way home, so they activated it when they got home. Brian, if you go to the next slide. So this was the study design. So ER discharge, we called them on day one. Hey, did your FUROSCIX pump work? Any problems? Everything's going okay. They came to clinic. We gave them 3 to 5 doses for that. They came to clinic, and then we reassessed them. We reassessed their volume clinically, and they could get more doses of FUROSCIX if they needed it. And then we followed them with phone calls out to 30 days to assess. And the other group was just standard of care. These were patients with historical controls, what happened to them, and we just followed them based on chart review. You go to the next slide. And Brian referred to this a little bit earlier. So out of all 24 patients, 3 sites, only 1 patient got readmitted within 30 days for heart failure. So we effectively U-turned 23 out of 24 patients out of our ER for heart failure using FUROSCIX. And not only did we effectively keep these patients out of the ER, the cost savings associated with that were tremendous. So about heart failure related costs alone, about $17,000 per patient saved. And overall healthcare costs are about $30,000. And Brian showed you some data up to $100,000 in some cases where patients had a complicated hospitalization and had a prolonged hospitalization due to a hospital complication. So a big opportunity here for health systems, especially who are bed crunched, to really try to use FUROSCIX. The thing here is to ensure stability, make sure the patients are stable. And what we found out consistently is most patients got through the first couple doses, they decongested well, and then they started congesting again. Having more FUROSCIX available for them at home to sort of like say, okay, I'm starting to get congested again, being able to treat themselves with a couple extra doses as they need it. And I think this is a real role for FUROSCIX is empowering patients. If you're a diabetic and your blood glucose goes up and you have to call your doctor for more insulin, like that's a problem, right? If you can just say, hey, I'm going to pull some insulin off the shelf and give myself a little extra, like that's the same feedback loop that Furoscix allows these patients in heart failure. They can say, I feel congested, my Lasix isn't working. I'm going to take a Furoscix off the shelf and I'm going to decongest myself. And for our frequent flyers, we've really created this muscle memory for them where they are self-treating. Now they know if they're taking two or three in a row and having problems, they call us and they let us know, or they'll call for a refill, so we kind of know where they're at. But it really has worked into our workflow. Next slide. So we want to leave some time for questions and other thoughts that you may have. But I think a couple really major points here, and Brian hit on most of these up front. Congestion's a big issue, right? It's the main driver of not just symptoms and admissions, but realize residual congestion is associated with worse mortality. Like we need to do better at assessing congestion. If you're not using a device somehow in clinic or something to objectively assess congestion, start thinking about what your options might be. We use a REDS device in clinic, which I think is just phenomenal. It's a point of care, it's spot, it's 45 seconds. We get a clear indication of what their lung water is, and we get to really understand where they're at. But have some objective measurement for these patients, particularly the post-discharge patients, to assess congestion. Realize that 90% of all heart failure admissions are due to congestion. So it really, really drives costs. Now, I don't want to take the focus away from guideline-directed medical therapy. Programs that focus on weights and symptoms and diuretics alone are insufficient. They have to be combined with titration of GDMT. But however you get to decongestion, whether it's with effective GDMT or the addition of loop diuretics, you have to get GDMT on. You have to make sure patients are decongested, particularly after a hospitalization. As we said, there's plenty of data based on dyspnea scores and other things that 40 to 50% of patients who get discharged from the hospital or have residual congestion. And we have measured this in our hospital. We've measured it in the clinic. We've measured it in the hospital using the REDS device. And these numbers are completely accurate. It's consistently 40 to 50% of patients are walking around congested. So aggressive identification of congestion, effective decongestive strategies are important clinical skills. I urge you to really hone those skills, develop those skills, know what works. Listen, there are some good podcasts about it. Brian and I talk a lot about, hey, struggling with this patient or I'm struggling with that patient. Like, how do we do this? How hard should I push them? And if all else fails, you go to a right heart cath and figure it out. Believe me, people who tell you that they can assess volume accurately on exam are totally full of crap, right? It is so hard to accurately assess congestion on exam. Physical exam is very specific. If you see it, you're probably right. If you don't see it, it's a coin flip. So realize that physical exam is lousy for congestion. And if somebody's walking around, I'm a master clinician, I can get it all the time. It's like complete BS, right? We compared our physicians to a REDS device, and we went to school for 15 years and we were right about 60 or 70% of the time, right? So we're wrong 30 or 40% of the time. Like that's a D. So do not feel bad if you say, I just can't tell. You feel good about yourself that you're honest and not don't lack skills. This isn't going away. Like as Brian pointed out, him and I were talking earlier. Like there are more and more heart failure patients coming. The recent estimate is 1 in 4 patients will develop heart failure in their lifetime. If you're not looking for heart failure, it will find you. And the second thing is we are losing 500 cardiologists a year, right? So if you look at fellowship graduation and you look at retirements are outpacing graduations by 500 doctors a year across cardiology. You guys are the future. You are going to be taking care of these patients. Understanding how to do this is going to fall into your laps, and you're going to have to understand decongestion. You're going to have to understand GDMT. If you're not comfortable with it now, get comfortable with it and work with people to understand these new strategies. And then finally, while these algorithms are beneficial, and I've showed you some things that I've used with our APPs and our residents and things like that, personalized approaches to heart. Not Nothing works for everyone, right? You're never going to get to a point where I always do this and it always works. Like if you like that certainty, like going to dermatology, right? Cut it off, it's gone. It doesn't work in heart failure. You have to, get comfortable with utilizing new diagnostics and also and new therapeutic tools. So know how to use Furoscix. Know that one dose isn't enough. Think about 4 doses. Think about chronic dosing at home and find that patient population who will respond to that. And I strongly encourage you when people say, let's just do it the old way is why we have not made a dent in heart failure readmissions and heart failure mortality. In fact, heart failure mortality is increasing over the years because the old way doesn't work. And we've been doing the old way for a long time. And I hope that programs like this allow you to become part of the new way and we actually make a dent into this disease state. So I think we got Brian, I'll get off my high horse. We got 12
Sure.
minutes left. Got 12 minutes left. I'll turn it back to you.
No, thank you. That was great, Dan. Um, I'll put this plug out there, and then I'll stop sharing the screen so I can look at the Q&A list. But please, this is a 2-part series. We'll be planning the second part where we actually talk about the application of Furoscix with real-world clinicians, both in private practice and heart failure clinics, advanced heart failure programs, rural hospital settings. So we'll be able to hear from them later in September. So stay tuned for that date. We will be sending out blasts on social media and email like we did before. And of course, please join us at our national conference in Nashville, which is November 13th through the 15th. Dan has graciously agreed to come talk there. So if you want to come and talk congestion with Dan, Nashville will be the place to do it. So let me stop sharing my screen.
Looks like we got a couple questions. All right, yeah, we got Michael Clark looks like he has a question. If you want me to hit that, Brian, or if you want to read it, however you want to do
Sure. Thanks, Michael. Glad you were able to join us. Dan, what are your thoughts and experiences about metolazone with furosemide or torsemide as an adjunct when Lasix just really isn't cutting it?
Yeah, so metolazone, you saw in the 3T trial, metolazone's a staple, right? We've always used metolazone as an adjunct. It's a thiazide diuretic. It's a great tool to increase diuresis. The thing I don't like about metolazone is that it has really it can have negative effects on electrolytes, right? We see a lot of hypokalemia, a lot of hyponatremia. So I just think metolazone isn't as smooth as we would like it to be. And I just earlier this week, as you can tell, I'm on vacation, but earlier this week, one of my favorite patients called me again with another defibrillator shock from after, the day after using metolazone. So yes, it's a great drug. We use it all the time. It's important, but I think whenever possible, I try to get away from it and use Furoscix, especially in people who've had electrolyte abnormalities and rhythm issues. It can really, really cause a problem. But is it ever going to go away? No, it's something as a someone who treats heart failure patients, you're going to need to be comfortable with. And I typically give 40 to 60 milliequivalents of potassium with every dose of metolazone I give.
Mm-hmm. So, Robert Ross, will this be available? Yes, we recorded this evening. Yes, this will be available for playback later. Dan, question, and you briefly touched on this, but I think this is something that's probably on every clinician's mind, is about operator error with this. And I know that when they developed this, they used a learning trial to show operational task with Furoscix. Can you talk a little bit about that?
Yeah, this was studied heavily. They did a lot of patient factor testing and to understand, how difficult was this? What amount of human factors testing? And this is a science. They put people in a lab and try to figure out different age levels, different acad training levels, and things like that. And they break every single task down to it, the smallest little thing. And if you looked at the human factor trials, like 98, 99% of people were able to figure this out without a problem. What we always do in clinic when we're doing this, I mean, I tell people if you can put on a belt, you can figure this out, right? It's really, really simple. But we always go through it. Like, my nurse shows the patient, we often have a sample. We'll show them with a sample and take off the adhesive and how to apply it. And then the patient will push the button when they get home to activate it. But we have not had a problem with people figuring out how to use this device. Um, um, Easily, problem. I will say that can't say too much about this as pre-FDA stuff, but there's the company has also plans for other ways to get this into the system with injectables and things like that. So I can't
Yep.
say too much more about that, but the subcutaneous delivery model for this is evolving, and I think it's a really important way for decompensated heart failure patients to be treated.
One of the things I'll point out, I get asked a lot when I do speak about the Furosix product, to different groups, um, is people get really hung up on labs for this, really hung up. And one of the things I usually tell folks is, if someone comes in, like let's say the ER, and they're very decompensated, they're clearly volume overloaded, you're going to wait for their labs to come back to slam them with Lasix? No. You're going to adjust uh, after the labs, if you need to replete the potassium and what have you. So, one of the things I want to tell our audience tonight is, if you've got a patient in here, don't think you have to have labs physically in front of your face right now to say this patient can or cannot have Furosix. If you've got a patient that will benefit from it, that clearly you need some help beyond what they're doing with PO diuretics, uh, check labs. Absolutely. You need to check labs. You need to check labs, and you'll know your patient. You'll also look at their other medications. But don't think, oh man, I can't give this to this patient today. I've got to wait and check labs. And, then they leave the clinic, and then you're starting to say, oh, well, let's have my nurse call them in a day or two. Those patients, you've lost that valuable time. Wouldn't you agree with that, Dan?
There's a couple of great points there. Once again, there is clear data that we have. It's small data, but it's that time to treatment's important. Delaying treatment is not good, especially when people have symptoms or if their weight's going up. We know when people have symptoms or their weight's going up, you have 5 days before they're going to show up in the ER, period. So if you're waiting, you just increase that risk. So that's number one. The second thing is, like, this isn't magic, right? It's IV Lasix. We give IV Lasix all the time. And the thing I like about Furosix as opposed to metolazone, it's a pretty predictable thing what it's going to do to most people's potassium, right? So, if I give them one dose of Furosix and their potassium is typically 4.2 or 4.3, I'm going to give them 40 of PO, 40 of extra potassium. If their potassium is typically 5.2, I may just give them 20 or nothing, right? I just have an idea where they are. But realize we've been given IV Lasix for a long time. Just give it to them, kind of understand where their baseline potassium is. If you need to give them extra, give it with them, and get labs in 1 or 2 days, just like you would do for any other time that you change their diuretics. There is no magic to this. If you even think that if you've ever used metolazone in the past and you're afraid of this, like, it's way backwards. Like, I'm much more worried about electrolyte abnormalities with metolazone or other products than I am with giving people IV Lasix or subcutaneous Lasix.
Absolutely. Um, Alyssa, saw your question. I know we kind of touched on the choosing a different loop diuretic versus adding metolazone. You kind of spoke to that a little bit earlier. But the second question, what are your steps after the injection? Do you have success with one time and then an increased PO dose? I mean, I think we saw some data earlier that shows, hitting somebody one time is maybe not always as effective. I think this is where the personalization comes down. Are there plenty of patients I've put a Furosix on today? Didn't feel that they were hugely volume up, but needed a little bit of a push in the right direction, and then we resumed PO diuretics the next day. Yeah, but more often than not, most patients probably need that second dose, sometimes even a third.
Yeah, I think I love this question. I think this question gets to the crux of the thing. Think about that ramp that you saw that Brian showed about hemodynamic congestion and turn it upside down and think about it like a cup, right? That's fluid. The symptoms are up here. The green zone is down here, right? With each dose of Furosix, you're coming down. So the first doses Furosix gets you asymptomatic. The next doses are getting you decongested. I think to get people to the bottom of a cup is a minimum of 4 doses. So if people are having symptoms, they're having weight gain, I'm typically thinking 3 to 4 doses for everybody, and then kind of reassessing. Now, the nice thing is if you have a REDS device in your office or something else like where you're using CardioMEMS or something else, you can actually measure it and understand where you are when they come back to the office. So it really helps to do that. But I would say if you're going to order Furosix, if people are congested and you're going to use this therapy, 3 to 4 doses at a minimum, and then have them have, often you can get 6 doses or 8 doses for one copay. So I tell them to use 3 to 4 and then have a few on the shelf. They can just sit on the shelf, and then they can use it as a backup like this. But that is the crux of the matter. Um, we saw it in the at-home trial. We did an at-home trial with Furosix. We saw exactly this. After 2 or 3 doses, people started going back up. Get them dry, keep them dry. And then you should, once you get them dry, uh, their diuretic susceptibility should be restored. And then you have to decide whether or not their baseline dose of diuretics was enough, or if you have to increase it. But Alyssa, perfect question.
Michael, again, the thank you for the question. Michael's out in West Texas. I agree. The IV Lasix therapy in office is too difficult, just too cumbersome. I know I personally don't use it in my practice. I recently switched from private practice into the hospital owned um, um, arena, and this is something that I've been able to bring with me. So I agree with that it's just too costly and very limited, Michael. But Dan, what's been your experience with third party payers for this?
So it just keeps getting better and better, right? There are Medicaid now covers it, and it's been a lot easier. But across the board, people are understanding that this is preventing admissions and improving outcomes, and there are still pockets of people where we're still not able to get it for, but the reps for Furosix have been really, really responsive, right? So you can what we often do is we can give people 1 or 2 samples, and then at the same time we give them samples, we put in a prior auth for that patient and say, okay, what does the copay look like for you? And if the copay is 0 or 25 or $50, it's cheaper than an ER visit. Then we'll say, okay, we've given you 2 samples. Now we're sending 4 or 6 doses to your home, and we're going to use this as home dosing. If it comes back where the copay is $200, which is more unusual these days, we get on the phone with the rep and say, hey, you got to help us with this. We got to is there a solution to that? And I would say for 85, 90% of people, we find a way to make it work. But I have discouraged my team from just passing out samples one and twosies here because it's the old adage, am I going to give you a fish or am I going to teach you how to fish? And we have to give these people a stable way of getting this. So if you're having problems, I encourage you to reach out to your rep, talk to your rep about how this works. This is a problem that's getting better and better and easier to fix.
Yeah, I know I got some information recently that where I'm at, we're near the military base, so TRICARE is definitely a big consideration for us, and I know for any of the participants that are on tonight that take TRICARE. I think some very promising things are on tap for that. We're 2 minutes after 8 tonight. I want to thank everybody for taking some time out of their Thursday evening to talk about heart failure and talk about diuretics and how to get people to pee more. And more importantly, keep them out of the hospital and keep them alive. Dan, I want to thank you so much for taking the time to spend with us this evening. And again, if anyone wants to really dive deeper into this, Dan will be in Nashville at the CAP meeting, so we can definitely talk congestion some more. But please be on the lookout for our part 2 series on FUROSIX that'll be coming out shortly. So have a good evening, everybody.
Thanks everybody for joining. Have a great night.